A very good evening to all. It is such a pleasure to have you all attend this CME, which is on the role of magnesium in pregnancy and complications. The speaker here today, Professor Narendra Malhotra, indeed needs no introduction. His bright and exuberant career talks a lot about him. To give a brief introduction of him, Professor Narendra Malhotra is a renowned gynecologist and obstetrician. He is the managing director of Global Rainbow Healthcare, Director Art Rainbow IVF. He is the director of FOGSI Manyata CSE, Director Project Positive Health Rotary District, Director of International Relations SAFOG, a National Director of Ian Donald School of USG. He is a professor at Sarajevo School of Science and Technology, Croatia, a professor at Dubrovnik International University, Croatia. In past, he's been the vice president of SAFOG and WAPM, past president of Rotary Club Agra, Taj City. He has been the past president of ISAR, ISPAT, IFUMB, FOGSI, AOGS, ICMU, and INSAG. He is the founder editor of SAFAG Journal and also a member of FIGO Guidelines Committee from 2014 to 2017. He is the chairman of SMRITI, which is an NGO, a new level of care. Additionally, Professor Narendra Malhotra is an advisor to IF units at Maulana Azad Medical College, JNMC Aligarh, SMS Medical College, Jaipur. His academic accolades are numerous, and all the young obstetricians and gynecologists know him from his published papers, chapters, and also his textbooks. He has presented over 500 papers to over 1,000 guest lectures in India and abroad, and also delivered about 55 orations. He has been the editor of 55 books and many chapters, and also been a part of the editorial board of many journals, which includes Revising Editor Jeff Coat, Revising Editor Donald Obstetric Manual, Revising Editor of FOGSI's Ultrasound in Obstetrics and Gynecologists. Apart from all this, we should not miss the number of prestigious awards which he is commendable for. Doctor, it is such a pleasure and privilege to have you here, and no one is more suitable than you to speak on the topic today on the role of magnesium in pregnancy and complications. Over to you, Professor Narendra Malhotra.
So very good evening to all of you. Mera sabko pyar bhara namaskar. Those who have joined and those who have registered in huge numbers for this lecture on magnesium, which is such an important topic and often neglected by all of us. So today we're going to try and simplify what magnesium does to the body and what is the role of magnesium in pregnancy. I bring you greetings from my hospitality of Taj, and as you know, a trace and constant exchange mode with the absorption, with the kidney, with filtration, with reabsorption in the muscles and in the bones. Give us an exact amount of what is there in the body. It provides it, what is in the blood, and disorders, kidney disorders. Magnesium is under tight control and fairly consistent levels of 1.7 to 2.3 milligrams per deciliter in the plasma in that level. Now, as I told you, less than 1% is in the plasma, what we can measure. There's tissue, the body, and the muscle and everything that has the other one. So when we measure only the plasma magnesium, it is erroneous and it cannot give you the exact status of what the magnesium is in the body. If there is a magnesium deficiency, it affects all the systems. The brain, tiredness, headaches, migraines, sleep disorders, restlessness, anxiety, irritability. Then in the shoulder and neck, pain in the shoulder and neck. In the heart, tachycardia, palpitations. In the women, uterine menstrual disorders. In the hand, cold hand and feet syndrome and tingling or ankles and in the thighs. I can't necessarily tell you that there is an adequate content of magnesium in the total body. Conversely, a low magnesium level is a clear indication that there is magnesium deficiency. This you need to understand because there are stores and there is in the blood. If it is less in the blood, it is deficient. But if it is normal in the blood, it still could be deficient in the stores. So because these symptoms which I just enumerated are not specific to magnesium deficiency and they're seen in many diseases, so we rarely suspect that this patient could be magnesium deficient. But when you do in the ICU settings, you see that hypomagnesium is often encountered. And when with all of us who are walking around and ambulatory, it may be still normal in the blood. So hypomagnesemia and magnesium deficiency are often wrongly used interchangeable terms because total body magnesium can be depleted with normal serum magnesium and there can be significant hypomagnesemia without a total body deficit. So it could be just less in blood and the stores are okay. And and this is how the magnesium is absorbed and excreted out. So we cannot use a magnesium test as a screening test. Why serum magnesium cannot be used for assessing magnesium status? Because as we have just heard and just told you that most of it is in the body tissues. So the blood levels may be underestimating the prevalence of a magnesium deficiency. And it is unreliable because most of the magnesium is intracellular in the cells of the bone muscle everywhere. And a decrease in serum magnesium is quickly compensated with the bone reserves. So there is actually no deficiencies many a times. However, if there is a deficiency in the blood, that means all the stores are also deficient. So that is a serious problem. So what are the subclinical magnesium deficiency or chronic latent magnesium deficiency? It is defined as inadequate magnesium intake or your ingestion and a concomitant plasma serum level of 0.7 to 0.85 millimoles per liter. And the interchangeable plasma magnesium pool is tightly regulated through renal absorption, excretion and bone reabsorption. So there it is there. And if it is depleted everywhere, then it will be latent. Why this subclinical magnesium deficiency is important? Because you cannot always ascertain whether it's subclinical or not. Because plasma level cannot tell us there is a deficiency. Because long-term dietary magnesium deficit, that means poor diet, will lead to a deficiency and then only the symptoms will come. And then determining by the symptoms alone is not possible because they are pathognomonic to many other diseases. So we have no definitive clinical universal measurement and clinical measurement signs for magnesium deficiency. So let us see then how do we assess? Well, serum magnesium, as I told you, is one way. 24-hour excretion in the urine or the fractional excretion of magnesium can be estimated. Magnesium loading test, you identify the patient with normomagnesium. So assess initially the absorption of magnesium and then indirectly it tells you the bone status of magnesium also. What is good is that magnesium concentrate in the RBC and this can give an early indication of magnesium deficiency. Isotope analysis not available everywhere, ionized magnesium not available anywhere, but these are the tests which are done. We usually ask for serum magnesium, or when you get a package of health package done, it is usually the serum magnesium which is reported to you. So red cell magnesium is the most commonly measured using atomic absorption spectrometry. This is now available commercially and it is highly sensitive market. That's what I told you, RBC measurement is a good measurement test. And when you do this, the range in a normal patient and in a pregnant patient will be different. So pregnancy and how it will be different. You see here, we have compared a non-pregnant woman with magnesium levels in first, second, and third trimester. Whatever you're using, milligram per deciliter or milliequivalent per deciliter or nanomoles, the levels decrease in the first trimester from non-pregnant and decrease a little more in the second and a little more in the third. So if the decrease is more than this, the normal decrease, then they will cause complications in pregnancy. So the evidence of low magnesium state in a normal pregnancy is that the mean magnesium intake in a pregnant woman is below the required daily intake, or that means low income group and the poor diet and not supplemented. Magnesium responses to TRPMG6, regulating the intestinal and the renal magnesium uptake. So if there is an increased expression of these in the 12th and the 37th week, then again will be a problem. But there is an inverse relationship between TRPM6 and the urinary magnesium secreted at 37 weeks, indicated increased demand of magnesium in pregnant lady. So this proves that in pregnancy, magnesium is required. Magnesium excretion in blood pressure at 37, 38, 39 weeks, pregnant women having higher magnesium excretion have a significantly higher systolic and diastolic blood pressure. So late onset pregnancy induced hypertension could be seen by more urinary excretion of magnesium and less serum levels. When we do see in non-pregnant, healthy pregnant, and statistically analyze these levels, the plasma millimole per is 0.93 in non-pregnant and 0.63 in healthy pregnant. As I told you, reduces. And the p-nuclear magnetic resonance spectrometry is also lesser, and also the micro millimoles per liter is also less. And the stats significant is seen in plasma magnesium, which is definitely lower in healthy pregnant women. So studies have shown that 15 to 40% of apparently healthy adults like you and me will still have subnormal serum magnesium. And once the serum magnesium is subnormal, that means your body stores are subnormal. And this indicates that there is a low magnesium state, which is more common in women. Proportions are much higher in postmenopausal women and women with diabetes. And then it is seen abnormal absorption regulating modified in PCOS, obesity, diabetes mellitus, metabolic syndrome, and systemic inflammation. So many women in the modern society with inadequate modern intake, magnesium intake, that means 440 milligram in pregnancy and 400 in lactation, and in normal non-pregnant 370 milligrams of magnesium in diet or in supplement. Now, this is what is the current requirement should be or for not to be magnesium deficit. So in pregnancy, then it has to be treated. So vitamin D deficiency is common in pregnancy, and this will coexist with magnesium deficiency. So high calcium, low vitamin D will affect magnesium absorption. So vitamin D has to be supplemented when you are giving magnesium. So you have to have all the micronutrients and all the micro minerals which have to be added. And intracellular, which is in the bone, and slowly over a period of 4 months, it will get used up and come into the blood, and then the appearance of symptoms would be coming. So even in patients with severe hypomagnesium, the clinical symptoms may come late because there is enough in the bones and the muscles, and that is good. But when you get deficiency, then these women would feel fatigue, vomiting, nausea, which I showed you in the first slide, and the leg crampings and weakness, which with pregnancy. So let's see in routine obstetric practice, magnesium deficiency may have a role on the epigenetics of the genetics. That is, nothing can be done about. So a good epigenetics would trigger the good genes. A bad epigenetics would trigger the bad genes, and that is responsible for the fetal origin of adult diseases. So these fetuses who are deficient may, in elder life, land up with cardiovascular disease, diabetes, hypertension, obesity, or very thin. So a dual teratogenicity may occur. Now, may be directly related to changes leading to the cardiac. So magnesium deficiency could directly affect and cause associated with the uterine hyperexcitability, so preterm labor and growth retardation would be there in magnesium deficient patients. Now, this is very important. And several studies have shown that when you supplement pregnancy, factors are reduced. So checking magnesium level can be 440, as we just told you. So when you look at the medicine textbook, the Bible, the Harrison's principle, you see hypomagnesemia due to rapid shifts of magnesium into the extracellular fluid, into the intracellular compartment can occur in pregnancy and lead to rapid bone formation of the fetus. That's it. Vitamin D deficiency. And when you treat the vitamin D deficiency, normal and reduced intake and urinary loss, and there'll be more prominent pathognomonic chronic magnesium deficiency. So the rapid shift from accelerated bone formation and the other preeclampsia, metabolic and chronic low-grade inflammation of the blood vessels and deficiency. So preeclampsia, if you give routinely magnesium supplementation to all patients with vitamin D3 and compare it with a study of biological trace element research serum magnesium at 20 and at term. So the causative role is kind of established, and this indicates there's a fundamental role of magnesium in the nutrition in pregnancy. So we need to supplement either by good nutrition or by adding as a supplement to it. And magnesium also is a predicting factor during the first evaluation of pregnancy. So when you review all the studies, because that is how it is done, and put it in the Cochrane review, and you review all the RCTs, and this was done in 2017, and you can see the red circles which I made. Higher reduction in frequency of spontaneous abortion and preterm was seen when magnesium supplemented. Prevention of pregnancy-induced complication was seen, like fewer preterm, 1,500 babies born as compared to placebo. There was an improvement in the course of pregnancy outcomes, and the pregnancy carried on healthy. And it acted as a prophylaxis for hypertension or preeclampsia. The prophylaxis for preeclampsia, fewer patients who were supplemented with magnesium developed hypertension. It could still be there because of other reason. And you see all of them some of them are beginning at 12 weeks and some of them are beginning at 20 weeks. And improvement of the course of pregnancy, treatment of leg cramps during pregnancy, which is very, very common. And here you could add the magnesium D3 supplement, fewer leg cramps, and then overall improvement in the course of pregnancy. So the magnesium group compared to control group had fewer hospitalization during pregnancy and fewer preterm births. So it definitely showed that there was an improvement. So PIH improvement in cramps, constipation, preterm labor, fewer pregnant women needing painkillers and spasmolysis, fewer children born with bradycardia and distress, and prevention of preeclampsia and eclampsia when you supplement. So magnesium these include the complications which could happen would be intrauterine growth restriction, fetal growth retardation, and gestational diabetes, preterm labor, preeclampsia. And of course, all these smaller nausea, vomiting, headaches, weakness, fatigue, leg cramps, and body aches, all that is always there. So this meta-analysis concluded that magnesium sulfate would be safe and has lesser side effects and is very cost efficient. And every pregnant woman should be supplemented with magnesium 240 to 480, that is 10 to 20 millimoles of magnesium daily. And magnesium sulfate should be started as soon as possible. So we say at 12 weeks and should be continued until birth or full term. And it should not be discontinued for some weeks because it helps in lactation also. And oral magnesium sulfate is contraindicated. The only contraindication is severe renal disease, renal impairment, because it is excreted by the kidneys. So that is there. So in fetal growth restriction, it may reduce the risk of FGR in fetuses. It will increase the birth weight and reduce the incidence of eclampsia by 50%. So we have a very, very nice only supplementation for magnesium. Then pregnancy-induced hypertension, if the blood pressure is high, proteinuria or no proteinuria, it is an abnormal vascular response to the placentation. There is an increased systemic vascular resistance. There is enhanced platelet aggregation, activation of the coagulation system, endothelial activation, the whole thing about PIH, and which leads to renal dysfunction. And it's an extremely inflammatory condition. And just giving only antihypertensives is not going to control it. So you need to have a complete vitamin D, magnesium, antioxidants, antihypertensives, and lifestyle modification and dietary modifications added to the pharmaceutical or the drug therapies. For about preterm labor and birth, magnesium may inhibit preterm uterine because magnesium is known to be a little, it's a very weak tocolytic, but still it will relax the uterus a little bit and lead to, it has been seen in studies compared with placebos that significantly lower magnesium levels were associated with deliveries before 37 weeks, preterm. And when you supplement them, the gestation went up to 37 weeks. Then these were studied with the red cell magnesium levels, and 105, control of 36. Women delivering prematurely between 28 to 36 weeks were charted in this study, and that is where the conclusion came from. So in hypertension, we have responsive genes. There are 26 placental from the PH pregnancy. These were studied, and we've seen that when pregnant woman and causes lesser intracellular magnesium, the normal pregnancies and PI pregnancies statistically different. So significant lower magnesium levels were found in preeclampsia. But here again, you cannot, because the analysis cannot be done, then you have to prophylactically supplement magnesium to all pregnant women. And this meta-analysis showed a proof that it could help in reduction of preeclampsia. So this was a meta-analysis which pooled in 7 RC, and it said it reduced preeclampsia by 24% and eclampsia even more to the tune of about 50%. So this hypothesis or this meta-analysis supports the possible prophylactic efficacy of supplementing all pregnancies with magnesium or micronutrients. So oral magnesium, our own Indian study, thing, screening done at 20 weeks, and there is, again, it was seen in this study, when you supplement with magnesium, the glycemic status of the woman with gestational diabetes was studied, and this probably improves. So hypomagnesemia, which showed in the study by Tanex and Hyunghao from China, hypomagnesemia causes impaired glucose tolerance, the requirement of magnesium increases, and magnesium supplement improves the metabolic profiles, significantly reduces the triglycerides. The studies were summarized again, and we review and a meta-analysis showed. So what should we be doing? The primary and the secondary outcome to look at rich in magnesium. So you have to guide your pregnant woman for eating this. And if you have no time, you can ask them to log on to the iMums app, pregnancy companion app, which we have delivered, which we have and Garb Sambad. So it's a very good app to be advised to all the pregnancies. So magnesium supplementation to be given, diet to be given, and all this will be improving the statistics of the woman in gestational diabetes. So with those few words and advising women to have a good diet of this and this, I thank the Pharmed company for giving me this opportunity to sharing some of my views on this micronutrient, micromineral, which is so very important in pregnancy, and it's simple, it's not expensive, and can be easily supplemented in the form of capsule, tablets, or dietary intake. So thank you very much for all of you for attending this. and I'm open to all or any questions which you may have, which you can put down in the chat and put down in the, yes.
Sir,
Someone can moderate the questions.
Sir, Dr. Jinnat Nasreen has appreciated this presentation, and she wanted to know, should we administer it prophylactically to all women or to only women who have risk factors of P
Which
or
I
GDM?
presented shows that after 12 weeks, if you supplement, you are adding a supplement. So if you add a supplement which has magnesium and vitamin D3 along with all the B complex factors which you add, and if you can get something which is good, yes, I would say after 12 weeks add it, and including omega-3 also.
So I think, sir, there was another question about the safety of supplementing oral magnesium in pregnancy, and I responded by writing that if we are keeping it in RDA, if we can select a suitable organic,
renal compromise patients, you have a problem.
Otherwise, it is totally suitable.
And someone is asking, can it be given to non-pregnant women? Yes, it can be given to non-pregnant women. It will help there also.
Yeah.
So it will help in non-pregnant diabetes, non-pregnant health, all the health issues. Yes, it will help.
So I guess all the questions have been.
Dr. J, a few doctors have raised their hand. And
Yeah.
Yes, let them come live and ask.
Yeah.
So one by one, you can allow them to come live, unmute.
Yeah.
Yeah, some adolescent name.
Dr. Lalita Agrawal, I've just unmuted you.
Yes, Mr. or Miss Adolescent, you raise the hand, unmute yourself and ask. Yes.
Dr. Indra Prasad.
Namaste, ma'am. Am I audible?
Yes, madam.
Yeah,
Your voice. Hello. Yeah, your voice is audible now.
Hello.
Yes,
your voice
madam.
is audible, madam. Please.
I'm practicing in a village forum, so they come usually.
Her internet is very poor in the village.
6 months. Is it the right time to start magnesium at that time? And
so there are 2 times when you have an opportunity. You can start it at 12 weeks and you can start at 20 to 24 weeks. Even if they come later, you can always start. There is no problem. So you can start at any time of pregnancy. But the best results will be when you start after 12 complete weeks or the 13th week and or 20 weeks.
Thank you, sir. Thank you.
Dr. Bhagyashree Deshmukh has asked, should we go for serum magnesium levels in pregnancy routinely?
We have, but as we are very sure that there is a hypomagnesemia in the serum and in the stores also, because the normal levels, immediately the body stores from the bone and the muscle replenish the serum levels in the blood. So it becomes normal. But if it is less, that means there is definite deficiency.
Dr. Tapas Goswami asks, is magnesium now the panacea of all diseases in pregnancy?
Asking non-pregnant, pregnant, that we answered that yes, it can be given to non.
No, he is asking, is magnesium now the panacea for all diseases in pregnancy? So he is asking whether.
So see, as our lifestyle worsening day by day, all the supplements are why in 20-30 years back, or when we were postgraduates, there were no, we used to go for walks, 40,000 genes in us, cancer genes. Every one of us is carrying cancer, hypertension, diabetes genes. So if you have not proper diet, so it could be magnesium is panacea, vitamin D is panacea, B12 is panacea, omega-3 is panacea. So it's because we're not getting them through food. So all this has become necessary to take as supplements.
So Dr. Tasmin Farzana Sahi has asked, how long to continue magnesium in pregnancy?
So you have to continue till lactation, because in lactation also it helps. So continue it after delivery also.
Dr. Sarita Gupta wants to ask a question. Dr. Sarita.
You have to give Dr. Sarita rights, no? Meanwhile, I am just
Yeah,
asking.
I have given that.
Yeah. Dr.
Yeah.
Sarita, you are there. So meanwhile,
You continue, Doc. I have given the
Dr.
rights.
Dr. Seema Chigateri asked that when to start supplementing magnesium in patients with high risk of diabetes.
So 12 weeks.
So her sodium level has gone up.
Now, if there is a kidney dysfunction, then you have to stop.
Drink more water.
Yes, because it's excreted by the renal system. So the renal system should be normal. If there is a renal compromise, then it will be different. Yes, whoever has this raised hand, which is known as adolescent, please speak up.
Yeah, they have the rights to talk also.
Kindly speak up.
Speak up, you are unmuted. This is heartening to know that a lot of people from the South Asian countries have joined in, because we, as an international director of the South Asia Federation of OBGYN, I have circulated this to Nepal and Afghanistan, which are the updated to all the recent knowledge. And of course, as a past president of FOGSI, I take this opportunity to invite you all to the AICOG conference, which is going to be held in Calcutta, and do come to and there you are. We will go to the Pharmed stall together and learn more about magnesium and D3 combinations which they have. So that's it. And of course, all the sessions, the scientific sessions which are there. So we have a group called as FOGSI Friends on Facebook. Please join that. FOGSI Friends, those who are active on Facebook and you know a lot about FOGSI in that. And the FOGSI Friends session will also be there in the conference on 6th of January in the main hall, 3:30 p.m. Do come for that session also. And of course, the current president, Dr. Rishikesh Pai's Badlav and Anemia Bhagao, we've been trying that. Please join in spreading awareness about anemia in pregnant women and the other diseases now you have. So good food supplementation will prevent women from many other diseases.
Doctor, there's another question from Dr. Seema, and she's asking when to start supplementing magnesium in patients with high risk for diabetes.
So we are going to give all diabetic patients pre-pregnancy also. And you can start pre-pregnancy and continue throughout pregnancy. But if they come to you in pregnancy, then start at 10-12 weeks. By 12 weeks, you must start.
Dr. Monica Gupta has raised her hand. You may speak now. You're unmuted.
Good evening, sir. Can you please tell how long are we supposed to give magnesium in pregnancy from 12th week till term? Will it not lead to PPH since it is a uterine relaxant also, or is the dose prophylactic so it won't lead to those complications?
So no PPH, even when we give MagSulf injections for when the delivery is about to happen, high dose, 2 grams 6 hourly or so. Even then it has been shown milligrams per day, which is a.
So we can safely continue till term.
With no increased incidence of PPH has been recorded.
So we can safely continue it till term.
Yes, till term and after delivery also.
After delivery for breastfeeding?
For breastfeeding, for lactation improvement, yes.
Okay, thank you, sir. Thank you so much. Thank you.
Sir, there's a question from Dr. Amrita Rai where she's asking, has the focus been shifted from calcium to magnesium for PIH, GDM and IUGR prevention?
So iron, calcium, amino acids, taurine, etc., vitamin D, they will always remain. Magnesium is an added one which can be added to the supplementations for prevention of PIH. There's no one single drug. You cannot shift. You cannot stop calcium and depend only on magnesium. You cannot stop omega-3. You cannot stop taurine and histine, all those amino acids. So those will remain as a pregnancy supplement, either by diet or fish and etc., or by supplementing in the form of tablets, capsules, or protein powders, whatever. So those are there already. This is an addition to all of those. It was an addition right from the beginning, but the more interest has been shown when the studies have now surfaced.
Doctor, there's a question from Dr. Chandra Jyoti. Do we need to monitor magnesium level when we are giving supplement?
No, not at all. Magnesium has a very, very high safety profile. So when you give it for eclampsia in injectable form, see the dose which we give, very high doses. And even the safety profile, the toxicity profile is very, very high levels. Oral is just milligrams.
Dr. Amrita Rai, you want to speak?
Yes, thank you
Yes.
so much. Good evening, sir. I just wanted to know which patients are contraindicated for such magnesium supplementation.
Only kidney disease, renal disease, pregnancy with renal disease. Renal excretion is poor. There are chronic renal disease or acute renal disease. You don't give magnesium because it's excreted from the kidneys.
Thank you, sir. The one more thing I wanted to ask: do we need to monitor, or we need to see for signs of magnesium toxicity?
No, this is going only we're giving in milligrams. There'll be no, the toxicity comes in huge. The toxicity dose of magnesium is very, very large. Even when you give for eclampsia, 4 grams in each buttock, alternate and 4 hourly, 6 hourly, we monitor only by knee jerk when we're giving in high, very high doses. So the safety profile of magnesium is very high, very safe. So no need to monitor anything.
Thank you so much, sir.
Doctor, there's a question from Dr. Seema Chigateri. Is there a role of IV magnesium in patient with severe leg cramps?
No. IV magnesium, injectable parental magnesium is given only for neuroprotection when you are expecting preterm delivery within 48 hours. So the fetus is neuroprotected and does not land up with periventricular hemorrhage. And it is given for severe preeclampsia, for eclampsia prevention. The Indian study shows 2 grams intramuscular or IV slowly or over the drip. And it is given for eclampsia, of course, for seizures protection. So it is a very, very good anti-seizure drug. So whenever the patient comes with seizures, the first thing you try is with magnesium sulfate. And don't try the Campos regime or the Finargan regime or the Fortwin regime or anti-epileptics. Magnesium is the best to control seizures.
Dr. Lalita has raised her hand up. Doctor, do you want to talk?
So if you have no other...
So, Dr. Narendra, actually, we are getting now a lot of messages thanking you for the excellent lecture. I think the queries have stopped and there are messages pouring in that the lecture was very informative and they are highly thankful to your lecture, Doctor.
Thank you. Thank you. You can just tell them how we are getting it availability.
Yeah.
Right. So something about what the capsule has, how much it has, and the dosage and how it is packed and given. So MGD3, I think, is your
Yeah. We have a brand called as MGD3 in India. That is magnesium glycine complex is the salt, which is the most bioavailable salt, and it comes in a tablet form. So the bioavailable magnesium per tablet is 200 mg. So based on the situation, we propose 2 tablets or 1 tablets to pregnant ladies with the indication Dr. Narendra has suggested. So MGD3 tablet is now already being used by a lot of gynecologists, and as Dr. Narendra had advised that now the awareness on magnesium is significantly on the rise, and MGD3 as a brand is available very freely throughout the country. Dr. Jay, you want to say a few words on it?
Yeah, I want to say that routinely we prescribe calcium in pregnant women. However, we have to understand that calcium and magnesium are the divalent cations, and they compete each other for cellular entry. And as a result, if there is a relatively higher amount of calcium, okay, normal dietary magnesium is also reduced. Now, there may be a question that these things were not there earlier, And why suddenly we are talking about this? We are talking about this because of the fact that, okay, there is increased awareness and studies are being done. And we are also seeing that if the proportion between the calcium and magnesium is not 2:1, it creates an imbalance in the mother. So therefore, magnesium is just the lost brother, which needs to come in and play its role to make pregnancy more successful, more physiological. That's it. So I would like to personally thank Professor Malhotra. That
Doctor,
really,
just a point. There are two more doctors. Doctor, two more doctors raised their hand. Dr. Sudha Salhan and Dr. Miru Keshkar. So we are just unmuting them.
Yeah.
Dr. Sudha Salhan, any questions?
Just I wanted to know the preparation that you have told.
Okay.
MGD3.
Thank you, doctor.
Yeah.
Okay.
I would like to personally thank sir. I mean, it is always a learning experience from you. Okay. Even in the simple things you bring in depth, and it's really a fantastic guide for us to understand, think, and research further. Thank you so much, sir. It's always a pleasure having you on board. Thank you, sir.
Thank you. Thank you, everyone who has logged in. Thank you for all the questions. Thank you for all the messages. Be safe and be happy, and a happy new year to all of you. Happy, healthy new year to all of you. Change your lifestyle if you're following the bag lifestyle. Wake up early, sleep early, eat the right thing, do yoga, do exercise, and then you need not take any supplements. But if you're not doing it, you have to take a lot of supplements.
Thank you, sir.